Okay, we're going to continue on and finish this out. Question number 2: in assessing clients who may be experiencing a depressive disorder, the nurse's top priority is to determine which of the following. So your key words here are top priority. Of course, we're going to do an assessment on this patient, and we would want to know all these things about the person. But if you think about it, our biggest goal is to prevent self-harm. So we really would want to assess what is the risk of self-harm with this depressive order, because that could be a serious complication with depression. And while the rest of our assessment would include all of these items, identifying if there is any self-harm would be the utmost thing. So hopefully that makes sense to everybody. This is just a good psychosocial continuum. You kind of look at what are the different end results from mild to severe disorders. People may be, sad in terms of their mood, but if it's severe, they're going to express symptoms of like total despair and really be very despondent, not just kind of generally sad, but very withdrawn and empty and just have almost no sense of a reason for life anymore. In terms of physical behavior, we'll go into a lot of things specifically to anxiety because that's our key disorder that we're going to focus on for this session. But you see things like crying is usually on a milder scale than somebody who is so despondent that they cannot physically move, or what we call psychomotor retardation. Thoughts, for mild problems, people will have some level of distractedness, and the worse that their condition is, it will result in just a total obsession with yourself, to be to blame, or confusion, cannot even process thoughts at all, or extreme delusional thoughts. And then for physical manifestations, people may have sort of low energy. For some disorders, it might be increased activity, physical activity when you think of anxiety, but then it would become much exacerbated, or to the opposite end of just can't function. So in a lot of diseases, though, you'll have kind of a low energy level, just not much wanting to participate, and then that simple thing then degrades into things like anorexia, inability to sleep. The level of energy or the level of withdrawal is to the point where they don't even recognize the fact that they need to bathe or do any typical activities of daily living. And we're going to talk a little bit about anxiety, just to introduce one of the major psychosocial illnesses that you see the most of usually. This is just a common emotional response to usually an unknown stressor. This anxiety can come from psychological conflicts that a person is involved in. It is often accompanied by physical symptoms, and we'll look at some of those. It can be considered mild, moderate, severe, or fully disabling. And sometimes anxiety is unconscious. In other words, the patient really doesn't recognize, they're displaying symptoms of anxiety, but you as an outside observer may recognize that that's what it is, and the person themselves not realize that they're having anxiety. These are just stages of anxiety that are listed in your textbook. And there's an even better, more detailed model. If you look at page 268, table 13-1, that will give you, I tried to summarize that here into some of the items, but it's not a full listing. But in general, mild anxiety is sort of a normal anxiety that's in response to events of day-to-day living. You think about your life as a student. Yeah, I'm kind of getting stressed or anxious because I've got a test that's coming up, and or I've been studying a long period of time, or doing some activity to where my muscles are tense. I feel a little restless. I kind of have this sense of unease, but I'm not totally distressed. I'm more just kind of a little apprehensive, and some of that is normal to usual living situations that kind of come up. And for the most part, we tend to be able to find ways to kind of relieve that stress, or find better coping skills, and be able to handle whatever it is eventually. Moderate stress, in that level of stress, the patient tends to just focus on their self and a need to relieve the discomfort. Sometimes they're less worried about the total environment. They're kind of easily distracted. Their attention span is kind of short. And that you may start to see some of the physical symptoms that you're going to see further down, in terms of just physical things that change. Maybe their heart rate's a little elevated. They may feel a little bit more, start to recognize that they're more stressed than they were under the mild stage. Severe anxiety, by contrast, really moves them from a mental status of can only concentrate, if at all, on one detail at a time. At this point, the rest of the world is kind of not a issue. They are focusing totally on themselves and the need to relieve that anxiety. They may have little or no concentration or attention span, so when you're trying to interact with them, they just may kind of like zone out to what you're even saying. They really cannot solve problems unassisted. They may have feelings of dread. They may begin to show signs of confusion. They may get very emotional. This is the point where it's so severe I've started crying now. And physical symptoms of like headaches, palpitations, true tachycardia. They may feel dizziness or nausea. You may begin to see muscle trembling, because they're just so anxious they can't. It has to come out somewhere in their physical being, along with things like hyperventilation, urinary frequency, and diarrhea. And then you move to the final stage of anxiety, or the highest level, and that's panic anxiety. All of you probably heard of panic attacks, but this level of anxiety, the patient really becomes unreasonable, irrational. You can't make suggestions to them. They're not going to hear what you're saying. They're unable to focus even on one detail. And they may completely misperceive reality or lose contact with reality. Other things that they might start displaying are shouting, screaming, running around, clinging to something that they won't let go of. They may become in total withdrawal where they will not communicate. And typically, communication just about ceases in any kind of reasonable way. They may express terror. Physically, you may see dilated pupils, labored breathing, severe trembling at this point, sleeplessness, diaphoresis, pallor, and even muscle incoordination because of the trembling and the stress in terms of how their muscles are responding to this anxiety. So as a caregiver, you're looking at how do I really evaluate anxiety symptoms? And this is just kind of a way to think about it. First, you look at observable behaviors. Is this person making poor eye contact? Are they displaying extreme restlessness? Are they starting to appear emotional? Are they having some crying? Are they trembling all over? And how severe is that? And sometimes you see very rapid speech as another observable behavior. Are there cognitive changes? What is their level of orientation? Are they having confusion? When you ask them questions, can they give you a normalized answer, or do they divert and change subject and can't seem to follow through with what you're asking? And then sometimes you'll see forgetfulness. You were in the room and you told them one thing, and then you come back 30 minutes later and they have no memory that you even had that conversation. That's a good example of how you might visually see forgetfulness. Objective physical data, these are just some things that come with it: sweating, rapid pulse, respirations, and go by your table in terms of kind of knowing which types of physical things you would see by the different categories. And subjective data. Hyperventilation is a true observed physical data point, whereas shortness of breath, the patient may say they're short of breath, but it's not exactly quantified by your measurement of the respiratory rate. So, and some folks will tell you they're nauseated or they're worried, and you may, or tell you I've not slept, but in reality maybe you work the night shift and you have seen them sleep, but they don't believe they've slept. These are some other assessment details. What symptoms are there? What is the intensity level? Is this normal anxiety, or is it something they're able to still adapt to, or has it gotten to severe? And then usually when you reach severe, the anxiety, as you saw on that table, really interferes with their ability to meet basic needs. They may have suicidal thoughts or plans. They may have assaultive or homicidal thoughts or plan. They're usually losing touch with reality and may have psychotic episodes. They also will have significant or prolonged inability to work or care for themselves or their family. And usually medical treatment with anti-anxiety meds and psychotherapy is needed when they get to the level of severe anxiety. We want to know, what is the etiology of the anxiety? Is it a psychosocial conflict that has caused the anxiety? Is it something related, a significant change in self-concept, body image? What could it be about that? So you have some of these physical ailments that come along with the anxiety. So which came first? The heart arrhythmia or the anxiety? Or were they having heart problems? And so now their heart rate's really up, not because of anxiety, but because they have a heart problem. Or is the anxiety driving up their heart rate, for example? So trying to get at which came first. You often see anxiety with COPD patients, and many of you have witnessed some of their respiratory problems. Were they having hypoxia or problems with their breathing that led to the anxiety, or were they anxious and that made them have a respiratory problem? And sometimes that's not as important, but in other times, trying to get at the cause, you're going to base your interventions and your goals based on the cause generally. These are just some typical goals or outcomes for outcomes that you might plan for anxiety. That they're able to plan coping strategies to put in place when they have anxious situation, that they learn and utilize relaxation techniques when these events occur. And then that as an end result, they're able to have periods of absence where they're not having those problems. This is just another long list of activities that you might want to put in a care plan. And then the third question relates to which levels. So make sure you know the levels and what goes along with those for testing.